It's changed. We lost a big wave.
So I'd like to wish everybody a good morning again, those who are attending virtually and also those here in Fustinalis. I'm Rob Chen, one of the members of the Division of Cardiac Anesthesia and Intensive Care, and I'm also our divisional representative for ERAS, the Enhanced Recovery After Surgery. Today's rounds is between myself and Dr. Alex Natsios from the Division of Cardiac Surgery. As is required by the Royal College for maintenance of competency points for these rounds, I have no disclosures, financial or otherwise. So the question to all is, why are we having these rounds? These are the survey results that were requested by Dr. McDonald. This is a couple of years ago, 2021. And this survey was actually proctored by our quality group here in the hospital. And you'll notice the respondents, some 6 surgeons and most members of my division, some 11 medical doctors. One of the questions that was asked is, should patients have no perioperative pain after cardiac surgery? You'll notice in the bottom, most of us said no in terms of being neutral or agreeing strongly. The same thing happens to the RN staff. But the corollary of that is almost half of us, MDs and RNs, think that that's possible to have no perioperative pain. If the patient has important pain, according to the survey, should we use a fixed dose, in other words, standing dose of analgesics? And you'll see most of us say yes, 90% of doctors, 90% of nurses, which is completely against the orders that we have, which suggests that everything is PRM. So what we believe and what we actually do has a harsh disconnect. When Dr. McDonald went on to ask whether or not we felt comfortable with our knowledge of best practices, more than half of us answered no, giving rise to these rounds. We're going to review ERAS, why it applies to us, and then how analgesia as practiced by anesthesia and surgery impact ERAS. So let's go way back. This is near the turn of the century. Dr. Fearon and Dr. Youngquist are one of the pioneers in ERAS. The ERAS started as a colorectal group. Dr. Youngquist says that this was part of his own patient experience as a surgical patient. They wanted to examine best practices as known in colorectal surgery, how it was applied across Europe. And the application is actually terribly variable. When they looked at complication rates from different European surgeries, centers for the same operation, the rate of complications has a 10 times difference. The length of stay for colorectal surgery, the same operation, has a 7-fold difference between centers. This is actually quite interesting. They rolled out ERAS in terms of best practices, and they looked at the adherence, and there's almost no adherence, which means ERAS itself has to be more than guidelines. We've now seen ERAS work out quite well in general surgery, and quite a few sacred cows have been slayed. If you think about the routine use of bowel prep and its dehydration signal, if you think about fasting, which has changed completely so that the patient's not additionally dehydrated, the reduced dose of drains in general surgery, early feeding without waiting for bowel sounds, without waiting for flatus, and then finally early mobilization, adding our physiotherapy friends or nursing friends in terms of that enhanced recovery. How did this affect the anesthesia friends practicing where colorectal surgery was done? Well, clearly, if you're going to have a carbohydrate load, these patients aren't NPO, and they did better. Multimodal analgesia, in other words, using opiates, but sparingly, was an important part of this, reacting to postoperative nausea and vomiting in a proactive or a prophylactic way rather than reactive. And then also observed in colorectal surgery that a high amount of fluids caused a different recovery, and a more balanced approach resulted in better. Does it work? This is from Thiele et al. This is published 2015 from the University of Virginia. This graph examines before and after, about 100 patients before and 100 patients afterwards. On the x-axis is the predicted length of stay using NSQIP data. And this is actually quite a high performing center. And you'll notice that much of the length of stay dark bars is actually below the NSWIC predicted. The light bars represent what happens after ERAS. And you'll notice that there is a leftward shift. In other words, there is a substantial reduction in length of stay in a high-performance center. What does this mean? From the economic point of view, about $7,000 saved per patient per admission. During this particular study, they saved about $750,000 just by doing the study. When we look at the patient's outcome, there is a survey that is used in all these patients. And the survey actually examines analgesia as part of the results. And this Press-Ganey survey actually demonstrated an increased patient satisfaction, better pain control, more patients satisfied, shorter length of stay, and money saved. And that's important in this particular university. So why is it important here? One, this is among senior management, our direction. We are now an ERAS center, and we have a quality group that is moving it forward, and we actually have an ERAS coordinator, and I happen to be the anesthesia representative. Why is it important to us? Well, the first part is capacity. We are a small hospital. We have a limited number of rooms, a limited number of beds, a limited number of ventilators, and most importantly, a limited number of staff. If our length of stay is shortened, then our capacity increases without examining staff or the facility. We have a wait list, and the faster we can address patients on the wait list because of increased capacity, the improved M&M we can have. And then there's a health economic point of view. The other thing that is quite true for surgery, whether it's colorectal surgery or cardiac surgery, is that complications happen in the postoperative phase. And we're looking at an enhanced postoperative phase, meaning a reduction of complications. We are also a center that enjoys important patient satisfaction, and we have an opportunity to improve it. Where does anesthesia come from in terms of opiates? Well, this is Dr. Winans. This was published at 1967. It's actually published in our journal. And this was the state of the art in cardiac anesthesia. You'll notice that pentothal was used up to 100 milligrams. And those of you who've used pentothal, that's 4 cc's of pentothal in a 2.5% solution. In this style of anesthesia, we know that pentothal was hypotensing. His death rate was about 13% all comers. And if you had rest pain, it was 1 in 3 all comers. This was a very important anesthetic risk. Dr. Lowenstein published in New England, this is 1969, just 2 years after Dr. Winans' papers. It's an observational study, and he used up to 3 milligrams per kilogram of morphine. These patients were spontaneously breathing prior to their intubation. Spontaneously breathing, just to let you know, 3 milligrams per kilogram. And what they noticed is these doses were tolerated. This is a completely different experience than pentothal alone. Yes, this is not Dr. Stolting. For the anesthetist listening, this is the Dr. Stolting who wrote Anesthesia and Coexisting Disease. He took Lowenstein's data from morphine and changed it into a 10 milligram per kilogram dose. This was infused over 15 minutes in order to achieve anesthesia. The patient's breathing spontaneously, and then they got succinylcholine. The succinylcholine went on to allow for intubation, and after intubation, halothane or droperidol or other medications. And 3 milligrams per kilogram was tolerated. Lowenstein, 10 milligrams per kilograms of morphine, 15-minute infusion, Dr. Stolting. Let's come back to Canada. Dr. Winans published again the fentanyl version, Dr. Stolting's study. In other words, this is now 100 mics per kilo of fentanyl. And once again, he had demonstrated quite a bit of hemodynamic stability compared to his 1967 study. This was groundbreaking. This was a new, safer way of delivering cardiac anesthesia. 10 milligrams per kilogram, that's almost 10 mics per kilo, sufentanil. It's a big dose. Why is this important in ERAS? Well, one thing we know about the side effects of opiates in terms of recovery, respiratory depression, and so on. The other thing that's important is as we think about opiate sparing or reducing opiates, the other side is still analgesia. we need to provide good analgesia. In all the other ERAS programs, multimodal, in other words, different agents, is part of it. And as we examine multimodal, we actually get better patient satisfaction. There are some additional risks with high-dose opiates. This is Dr. Chase Brown. He published in JAMA just 2 years ago. He surveyed over 25,000 patients. And what he discovered, and this is the US experience, that if you had an important dose of opiates upon discharge, you had chronic opiate use after cardiac surgery. So to put it in the ERAS style, poor analgesia, using mostly opiates, causing opiates at discharge, opiate chronic use. This is American data. Purdue Pharma has a big impact in the US. Does it happen in Canada? Well, this is Dr. Kogan from the Montreal Heart. And she's published that if you have postoperative pain, you have a 350% increase in your chance of chronic opiate use. What are the risks? Younger age, longer surgery, this makes sense. And also your experience of pain. The higher experience of pain, the more you have a chance of chronic opiate use. What are mitigating factors? Interesting, perioperative gabapentinoids, acetaminophen regularly. And the other mitigating factor is regular assessment and reaction to that assessment. We know of these perioperative options and we've all used it. We think, do we use it? I had the EPIC data people pull the first 1,000 mixed surgeries. And the reason it's easy 1,000 is the data beside translates into percentages, which means less than 0.5% of these patients had blocks by my surgical colleagues. 3.2% of these patients had blocks by my anesthesia colleagues. Almost 5% exposed to ketamine, in other words, multimodal. 1 in 20 were exposed to multimodal with ketamine. About the same amount for NSAIDs, about 1 in 20 had multimodal, 1 in 20, and then 10% had a gabapentinoid. 13% of these patients during their surgery and recovery time had experienced moderate to severe pain, a visual analog scale of 7 or more. And if we think about the risk with chronic pain, which is to say we know it, but we don't do it. I do take these data, they're pulled out by non-clinicians, and there could be data missing, but it paints a picture. And I invite my colleague, Dr. Natsios, to continue the picture.
Thank you very much, Dr. Chen. Just going to pull up my slides as well. I just want to confirm with the audience that you are seeing my slides, okay?
It looks great.
Great, so thank you very much, Dr. Chen. So I'll continue and discuss multimodal analgesia and ERAS in cardiac surgery with respect to the postoperative management. I want to first thank Menika for really providing her wisdom on this topic and helping me prepare this presentation. So the key themes that I want to cover are the following. So firstly, shifting the focus of our postoperative analgesia and cardiac surgery on patient function. Number 2, analgesia should be individualized to the patient rather than protocolized. Multimodal opioid analgesia, opioid-sparing analgesia is a win and really represents the cornerstone of ERAS recommendations as far as analgesia. And then finally, NSAIDs after cardiac surgery are not necessary. So before talking about pain, and analgesia in cardiac surgery, it's important to understand the pain pattern seen after sternotomy. As this pain pattern is very unique compared to other types of pain experienced in surgery and other medical conditions. Pain in sternotomy starts after the first few days and really peaks around 48 hours. And after this, there is a drastic improvement in the next few days, from day 3 to 4. By day 6, 7, pretty much every patient, as seen in this figure, will return to somewhat of a pain-free state, no matter really what we do in the first few days. So what is the goal of analgesia post-cardiac surgery? So as we know, suboptimal pain control has downstream consequences, and all of the above, all these complications extend hospital length of stay after surgery. So it's important to treat pain when it's there. The first 48 hours, therefore, represents a window of opportunity for us in surgery to impact the function of our patients post-operatively, really setting the tone of a patient's recovery in hospital after cardiac surgery. The focus in the first 48 hours should be multimodal analgesia, as Dr. Chen alluded to, if possible. And if needed, the use of opioids can be used at the appropriate dose in order to improve the functioning of our patients. When titrating the analgesia, we should not focus and get carried away based on 10-point pain scales, but we must rather focus on functioning, mobility, how patients doing, providing enough analgesia for the patient to participate in their rehabilitation. I think this example illustrates some of those points. This is a post-operative patient from the last few weeks who, from day 15 to day 20, reported onwards of 7 to 10 out of 10 pain, despite functioning well, ambulating 120 meters, being independent. Still reported this degree of pain, and you can see for this degree of pain she was receiving up to 40 milligrams of morphine on day 15, despite being in a pretty functional state. So this phenomenon is what is described as pain catastrophizing. And pain catastrophizing is really the ignition or match for what is described in the pain literature as the pain fear avoidance cycle, where pain is linked to functional debilitation. And we see this happen, and it's incredibly difficult to manage, like in this case, in the post-operative setting. Therefore, our optimal analgesia optimal analgesia really starts actually at the preoperative phase with management of expectations. So preoperative counseling to manage expectation is one of ERAS's first recommendations, and expectation management that the pain will be part of the process in surgery at some level. And our goal with analgesia is not to create zero pain, rather the goal is to improve functioning and enhance recovery. Not only is this important to be implemented at the preoperative phase in our prehab programs in cardiac surgery, I would argue this should be implemented as part of our surgical consent process routinely, as it helps to reduce, as they say, perioperative fear, fatigue, discomfort, and enhance recovery in earlier discharge. So that brings me to my next point, that analgesia should be individualized. Pain is individualized, analgesia is individualized. I'll keep this part short, but all to say is that we should avoid protocolization and regularly assess our patients, always asking ourselves, what is the etiology behind their pain? Is it somatic pain driven by bone or musculoskeletal pain? Is it neuropathic pain driven by intercostal nerve related to surgical retraction? Or is this visceral pain derived from the pericardium or the pleura, all which have varying managements? We have to consider the patient factors such as renal function or concomitant comorbidities they may have. we always must think about the delirium risk when it comes when we're thinking about multimodal analgesia. Now, when it comes to opioids, one size does not fit all, and we know this. We must understand that some patients just require a little bit more, and this can be indicated based on their size, prior opioid use, or can be reflected by the requirements of hydromorphine requirements immediately post-op in the CSICU. In our initial 48-hour window of opportunity to treat pain, we may need to optimize dosing as long as we are titrating and focusing on patients' functioning to allow them to participate in early recovery. My next point is opioid use and discharge. So as Dr. Chen alluded to, there are harms associated with opioid use in the long term and with respect to the opioid crisis. When writing a discharge prescription, we should always therefore be cognizant of this figure, that it really only takes 4 to 5 days of opioid use to increase the risk of dependency in the long term. This sentiment is reflected in a recent consensus document out of the University of Toronto on prescription of pain medications at discharge after elective adult surgery. They really stress that opioid use should be prescribed based on a reflection of their last 24-hour consumption and avoiding them, if possible, on discharge, with focus on non-opioids and analgesics as first line of treatment. I would acknowledge that I think for the most part in our program, we were able to achieve this result. However, I think there are still some aspects of improvement, which I'll illustrate with the following example. So this is an analgesic record from a postoperative patient from two or 3 weeks ago. We note here on the right side the efforts for multimodal analgesia in the preoperative phase and the immediate postoperative phase for the first 2 days. However, as you can see, as certain elements and aspects of our care map expire, such as straight Tylenol, which routinely falls off the care map after 72 hours, and other multimodal agents were discontinued, the patient then reverted back to traditional opioid regimen on day 3, day 4, and day 5, just prior to discharge, leading him to go home with an opioid prescription on discharge. So how can we improve our use of multimodal analgesia? I think going back to our model, in contrast to that first 48 hours where we want to treat that acute pain, I think as we are nearing and approaching discharge, we should begin to think about transitioning to an opioid sparing regimen, continuing multimodal analgesia, but setting up the patient's discharge to go home without opioids if possible. And we'll review some of these agents as recommended by ERAS. First, let's discuss the ERAS model and philosophy. So as compared to traditional care, which is really provider-driven and driven by physician preferences, therefore can be extremely variable and somewhat of a passive process. The ERAS model is a standardized process that is active and that's based on evidence, with goal of expediting discharge after surgery and optimizing hospital resources. With respect to analgesia and multimodal agents, they recommend the following agents. So Tylenol to be dosed straight, if possible. They do recommend Tramadol, which is effective as an analgesic, but they note that there is a high delirium risk. They recommend Gabapentinoids, which we know are effective for the neuropathic component of pain, dexmedetomidine, as well as ketamine. They recommend the use of a variety of these different agents in order to target the different mechanisms of pain seen in cardiac surgery. Avoid opioid use when possible, and always transition to an oral opioid regimen when we can in order to set the patient up for discharge. The recommendation on a class 1 basis, level B evidence, is that there's sufficient evidence to recommend the use of acetaminophen, Tramadol, dexmedetomidine, and Gabapentinoids for the multimodal opioid-sparing pain management. And this recommendation goes hand in hand with what we know from the WHO model, which also promotes the use of these non-opioid agents around the clock regularly, and use of opioids, therefore, as breakthrough if needed. Now, does multimodal analgesia have any evidence in cardiac surgery specifically? Turns out there is some. So this is a randomized controlled trial out of Denmark that looked at patients in cardiothoracic surgery, randomizing them to either traditional analgesia with morphine, opioid based, compared to a multimodal approach using the following regimen. So Tramadol extubation with precedent postoperative Gabapentin, Advil, and Tylenol. They found that multimodal had less opioid use as expected in the first 24 hours, but as well had better average pain scores with the first from day 0 to day 3, as well. This was associated with a reduction in GI side effects by avoiding opioids. This RCT similarly looked at single dose of gabapentin given preoperatively at 600 milligrams. And this was associated with a reduction in opioid use, as well as improved analgesia in the first 48 hours. We'll note here that there was a signal for increased sedation seen at this particularly high dose at 12 hours. So while ERAS provides recommendation on what agents to be used, it actually doesn't specify exactly how to best use them. So how does multimodal analgesia fare when actually being implemented in a cardiac ERAS program? 2 centers so far have published their experience with implementation of their cardiac ERAS programs. So first, Johns Hopkins in 2019 looked at 400 patients after implementing these ERAS measures, which included multimodal analgesia, fast-track anesthesia, and the use of nerve blocks. They stratified their patients to either high ERAS compliance, so more than 5 of these measures, or low compliance, less than 5. As you can see, since implementation, a variety of these different measures has been increasing. Patients that had high ERAS compliance, as time went on, had a higher incidence of earlier extubation within 6 hours. And furthermore, had a reduction that was significant in their hospital length of stay by 19.4 hours. The experience out of North Carolina looked at 1,000 patients since implementing their cardiac ERAS program, and compared it to a cohort of patients pre-ERAS. Their bundle included preoperative Tylenol, gabapentin, intraoperative Tylenol, hydromorphone, and dexmedetomidine, postoperative Tylenol, gabapentin, and oxycodone. This was also associated with a reduction in opioid use in hospital, reduction in ICU stay, and an overall reduction in hospital length of stay from, again, 7 to 6 days. So although ERAS introduction was shown to be effective in these 2 retrospective trials and with earlier discharge in these programs, it is important to recognize, I think, the limitations of these 2 studies, as it's non-randomized observational evidence. We have to ask, is this effect in earlier discharge actually due to the above ERAS interventions, or is it just a result of a culture shift towards earlier discharge in general? There is one randomized controlled trial looking at ERAS in cardiac surgery coming out of China. This study was a single center RCT looking at 226 patients undergoing valve surgery, low-risk valve surgery, randomized to either the ERAS pathway or the control group, which was the traditional pathway based on individual physician preferences. The primary endpoint was readiness for hospital discharge. And they used the above bundle with preoperative block, fast-track anesthesia, and postoperative patient-controlled anesthesia. Analgesia with fentanyl and bupivacaine. they found that the primary outcome of readiness to hospital discharge was similarly reduced from 7 to 6 days, and this was statistically significant. This was associated with, of course, a reduction in overall hospital costs. So now, although I've shown a bunch of different permutations of multimodal analgesia strategies, I think the key takeaway from these studies is not necessarily about which strategy to employ or which strategy is best, but I think and really any effort towards multimodal analgesia resulted in an expedited discharge after cardiac. So for my last point, on the topic of NSAIDs, I hope to just clarify and maybe demystify this topic a little bit, going over what evidence is available. In 2005, this randomized controlled trial in the New England Journal of Medicine looked at the use of COX-2 inhibitors, paracoxib and valdecoxib, after cardiac surgery, and found that when they were used, there was a significant signal for MACE and thrombotic events after cardiac surgery, relative versus 3.7. Now, this effect was seen in COX-2 inhibitors in the general non-cardiac surgery population, of course, as well, and as we know, led to their withdrawal from the market. These results led to an FDA issuing a black box warning for all NSAID, against all NSAID use in the post-CABG setting, as you see here. So to understand NSAIDs, we have to understand that they're not all made the same. Some NSAIDs are primarily COX-1 inhibitors, such as naproxen, ketorolac, or the most common NSAID to be used in cardiovascular medicine, aspirin. These have more of an antiplatelet effect, of course. Some NSAIDs more selectively target COX-2, such as celecoxib or valdecoxib. And it turns out when COX-2 is selectively targeted, it tips the balance of prostaglandins towards a prothrombotic endothelial state, and therefore carries a vascular risk, as we know. So this is the largest meta-analysis that looks at the use of NSAIDs and their side effects. And what you can see here is naproxen is clearly the safest NSAID with respect to cardiovascular risk, and pretty much carries a neutral risk of creating cardiovascular events. And you can see that how this compares to our COX-2 inhibitors and even something like ibuprofen. Now, how about the use of NSAIDs in cardiac surgery? So this is a randomized controlled trial done at our very own institution in 2004, looking at postoperative naproxen administered routinely after cardiac surgery compared to placebo. What they found is that, of course, naproxen had a great analgesic effect on pain control within the first 4 days, but as well improved lung function. When you looked at the postoperative outcomes, there was no increased incidence of cardiovascular events, AKI, GI complications, and transfusion. So this could suggest that potentially that they were maybe not as harmful as we might have. They were made out to be previously. And this mindset is reinforced by many physicians today treating post-CABG patients. As you see here, NSAIDs use continues despite the black box warning issued in 2005. This is a cohort of 90,000 CABG patients in the United States, and NSAIDs were used in up to a third of these patients post-CABG. Primarily, this was comprised of ketorolac, 90% of the cases used on postoperative day 1. When NSAIDs were used, they were used on average 2.2 days, which corresponds to our initial short course of window period to really act on function. Potentially, this suggests that in very select patients, NSAIDs can be safe and are definitely a valuable analgesic in our multimodal toolbox. And then finally, I just wanted to put in perspective where multimodal analgesia falls in respect to the entire ERAS recommendations at the preoperative, intraoperative, and postoperative phase. Importantly, highlighting that there are many other evidence-based practices we haven't talked about today in implemented in the ERAS program that definitely contribute to efficacy towards earlier discharge in cardiac surgery. So just to summarize, my main points: number one, focus on function and getting our patients functioning after surgery, not treating numbers. We need to be regularly assessing our patients and assessing their pain in order to individualize analgesia. Multimodal analgesia is effective, and I hope I've shown that today, and really is the cornerstone of the ERAS recommendations. And then finally, NSAIDs in very select patients can be helpful. Thank you very much.
Just shy of 8 o'clock, and for those in the room or those online, are there any questions or comments to Dr. Nancios or myself?
Wondering what the history was in terms of only having 3 days of straight acetaminophen.
So that's a great question. We have a long history in the Heart Institute where many things have been protocolized to allow the prescribers to play many roles, whether that role is in the operating room, the intensive care units, whether that role is non-clinical. And what a protocolized order set allows the patient is to move forward through a typical course without needing the additional interruption of an assessor who would then make a decision and then stop a drug. And so we have many things that are protocolized just for flow. And so this is historic in terms of our staffing. The other thing that's interesting is when you look at the anesthesia protocolization, just as an example, ours came, the EPIC orders now came from our paper orders, which came from another century. When you look at our orders, we have moderate doses of opiates as a pre-medication, and we have smaller doses of a GABAergic medication and no other multimodal. It's become the practice of our clinicians in the PAU to add multimodal, but when you look at our orders, they represent something quite historic.
It was more a question of why 3 days and not longer.
For post-op.
For post-op, and there, once again, that's to allow
Somebody was supposed to reassess at that point.
it's a great question, and I don't practice on the ward, so that's difficult for me to imagine. It certainly is easier to have something drop off. For the anesthetist in the room, I've been practicing cardiac anesthesia for a couple of decades, and I don't know what happens when the patient is discharged. I was actually surprised to find out that most of our minimally invasive surgery patients actually go home with a very, very, very small dose of opiates. Most of them are instructed to take standing acetaminophen for another 1 week to 2 weeks. And all of them come back to the early access clinic quite pleased that they've taken no opiates upon discharge. Dr. Al-Sayed.
As regard to post-operative discharge, I'm just adding a comment. The problem is two things. Number one, the culture. There is the perception that every single cardiac patient should be in opioid. And the number two is multi-hand in the same patient. So your point is patient was minimal invasive, go home with this opioid, that mostly or mainly because there may be one team who is taking care of that patient. The other patient are different. You send the patient home without opioid, few hours later, some other clinician will fax prescription for opioid. So you are right. We are now working on a historical data. We should update our practice according to the new evidence. And also there is a big room to improve. Number one, to shift the culture, and number two, try to have one team taking care of one single patient, and this for sure will improve our practice.
Dr. El-Sayed's comment is very valid. And in truth, as a clinician, writing an opiate prescription is easy, as opposed to the assessment, as Dr. Nancios suggests, what kind of pain? Is it somatic pain? Is it visceral pain? Is it neurogenic pain? However, I know that if I write an opiate prescription, that it will satisfy the patient. The other thing that he mentions in terms of modernization, if we think about surgical practice, we went from a Weinberg procedure, safe. It was safe, without question, some patients survived, to all venous grafts, safe, without question, it was safe, patients survived, to arterial grafting. And we've seen this modernization, and I think what ERAS has asked anesthesia and perioperative prescribers is to modernize as well. There's more comments,
Oh, yeah, just a comment.
please.
So, thank you for clarifying the NSAIDs, because, as a pharmacist group, we were wondering. Still in our pharmacy references, it still has that black box warning.
Absolutely,
Yeah, so in naproxen, I just looked it up, it still has it.
yes.
So really appreciate the clarification.
Absolutely. So without question, that black box warning is there. And I guess the privilege we have as prescribers is to examine the evidence, and then we could actually use medications off-label. So for example, from a pharmacy point of view, haloperidol wasn't conceived as an antiemetic. It works. Propofol wasn't conceived as an antiemetic. It works. And IV lidocaine was initially conceived as an antidysrhythmic, and yet it has an analgesic signal. So I think we, as prescribers, examining the evidence, weighing risks, can decide what to move forward. Without question, the black box exists. But it's interesting that the black box came from one era of NSAIDs, and it was applied broadly. So the question becomes, is it a class effect? And what is the class? Is the class COX-1 or COX-2? You'll notice as from a pharmacy point of view, the rate of COX-2 use has changed over the last 2 decades. And I would suggest some of the early evidence of COX-2 was challenging. And we've discovered now, after we've retracted enough paper, COX-2s are hardly used at the same rate. So is it a class effect, or is this a COX-2, which is a different class of medication with different evidence for its efficacy perioperatively?
And the study was from 2015 online here.
Dr. Nancios, I think there's a question online. You might be able to see the chat.
Yep, so Dr. Lambert has 2 questions. Number 1, we have insulin sliding scale based on measured glucose. Why can't we have analgesia sliding scale based on regular pain assessments? And number 2, is there a role for PCA pumps at the UOHI?
I think that's a great thing. So sliding scale means that a RN reacts to the measured glucose with a insulin calculator that's been workshopped that we think is safe in this setting. And our RN friends could have an accurate assessment. And then the next phase comes back to Dr. Nancios's question in multimodal. Is that 7 out of 10 neurogenic pain from retraction? Is that 7 out of 10 from visceral pain? Is it coupled with ECG changes, which suggest pericarditis? Did the person have soft heart sounds that sounded more rubby? And I would suggest that individualization belongs in the hands of a prescriber. But it's an excellent comment. The PCA is the second part. And as you've observed, and it's been seen by our surgical colleagues and our colleagues in the ward, the second day is the worst. And I think PCA asks us to use more opiates on the second day, and ERAS asks us to use different mechanisms on that second day. First, we need to acknowledge when pain happens for the patient, and knowing that there's a rhythm of pain, I think the greater complexity of a PCA asking for more opiates is perhaps not the answer. Dr. Spee.
The first thing I want to say is a comment regarding Tramadol. People should be reminded that it is a synthetic opioid. It's very important because just like in one of the slides that you presented, and in some papers on pain control, they almost suggest that it's not an opioid. It is. and it's just as addictive as the morphine or fentanyl. The second point that I have to comment, or maybe a question, is that if we use NSAIDs, I think that what is often missing in many of the studies is a dose effective. At least we should aim for the lowest possible effective dose, and this is not always well documented. To my knowledge, one of the drugs where it's well documented is for ketorolac, but I'm not too sure about the others, at least for cardiac surgery.
Yeah, Dr. Dupuis's point is excellently raised in that in radiology, ALARA makes a lot of sense, and perioperatively, sometimes we choose what we think is safer, for example, 100% oxygen. But in every setting, it should be the lowest dose effective. And you're right, in ketorolac, initially 30 milligrams was common, and now the idea of titrating up, and it makes sense, the idea of titration to every prescriber. As was suggested by Dr. Nancios, everybody is not 1 to 2 Q4 of hydromorphone. It's a titration. It's an important point.
Any comment?
Dr. Rural, you have your hand up.
Yes, thank you. Thanks so much. Great rounds, everybody. And it's really, I'm really thankful. Actually, I do have a few things. I want to thank Cheryl and Carrie, who've really put this together along with Beth to really find the date. And we need more of those rounds together. And we're working on that, as several of you know. I also want to thank Menaka, and really from the content expertise leadership, Menaka and Roy, Dr. Masters, and Martin, really who's worked under the really the support of Bonnie and team to move ERAS forward, and Samantha prior to her mat leave, and of course Syed and Amy and both of you, Rob and Alex, who gave a really fine presentation. Now here my comments, I think it's, you know, we are making strides and we're really moving forward on this. And part of this, it was mentioned in passing, but part of this is the fact that we now have, for many patients, a rapid assessment clinic, right? Syed was alluding to this earlier. Syed really represents the trenches of this, you know, the full patient picture, like Menaka and others, from beginning to end, from pre-op preparation to how they do months later, right? And I think that assessment clinic allows us to send the patients home on post-op day 2 in a safe manner, also in a comfortable manner for the patient. One of the problems here, as Saida was saying, is that, you know, there's a huge element of culture, and in fact, culture takes precedence because the research is relatively low quality, right? There's all these observational comparative effectiveness studies, which basically mean nothing. And even the RCTs are geared toward the outcome that the intervention goes to, and not patient safety or even overall patient experience, right? If someone is booted out the hospital after 3 days or 5 days, or do they really have a better patient and family experience? And I don't think we really know that. But I was happy to see that the Heart Institute was denoted. Dr. Bedar and yours truly were first at the time, and I think Jean-Yves helped out quite a bit as well in putting this naproxen trial, which has turned out to be long-lasting and with durable insights. The last thing I would say is that as we move forward in this, I'll make a plea as a division head, it's important that surgeons remain involved, not only in the research and developing the content expertise, but also in decisions that we make, right? We don't want to be falling in a cycle where, for instance, you know, one division works in isolation of the other. And I know that's not the intent. Precisely, that's why we're having these combined rounds. And I salute the initiative, and I think it's wonderful. But there are other famous institutions in Ontario where, for instance, every single post-op CABG or heart surgery patients referred to an acute pain service, and their length of stay numbers are extremely poor, and they're not able to get their minimal invasive program up to speed, etc. I would say, although the surgeon is not a content expert with regards to exactly how analgesia works, etc., and I think the survey really conveyed that, the surgeon in the same token has the full picture of pre-op to post-op to weeks, days, weeks, months, and years later. So I think that's important. We have functional data, and as many of you know, we're doing the first randomized a clinical trial looking at post-op recovery of minimal invasive versus conventional bypass patients. So I think this is wonderful. Stay tuned. There's another combined rounds between our two great divisions next week on the 25th. We'll do a bit of a constructive update about the robot. And I think Rob and Alex, you did a fantastic job, and everyone in the background who made that possible.
Thank you, Dr. Royal, for your comments, and all of them quite appropriate. The evidence is building, and one of the opportunities we have here at the Heart Institute is to create evidence in cardiovascular science, cardiovascular anesthesia, cardiovascular surgery. We're actually recruiting a member who has experience in cluster research, and this is exactly the topic where the cluster mechanism work. Your comment about surgical leadership is key. Part of ERAS is to make sure that, one, the discussions are multidisciplinary, cross-disciplinary, and two, without question, how the surgeon counsels their patient is very, very important preoperatively. When we did our survey, a surprising number of our patients told us that they expected no pain. I had the absolute privilege, and people in this room know, to care for a cardiovascular surgeon post-operation, AVR cabbage, and they were actually astounded at the pain they experienced post-operative day 1, post-operative day 2. So an experienced cardiovascular surgeon was actually surprised at the analgetic requirement. You're absolutely right. Pain service slows us down, and slowing us down is not the idea of ERAS. It's not to boot somebody home. It's to increase capacity and improve the patient experience. There are other things to look at. And the way to examine is exactly as you said, Dr. Well, is to study it compared to historical norms, in other words, cluster. Postoperatively, without question, patients' early access to an assessment is key to safe early discharge. When you think about typical ERAS studies before and afterwards, and I also acknowledge the Hawthorne effect is very strong in studies like this, saving 1 day at the Heart Institute in terms of length of stay is equivalent to building another floor. I have leaders in this room, Dr. Dupuis, who knows what it is to build another hospital. ERAS is essentially building another floor in this hospital without spending money and instead saving money. It's an interesting concept.